All right, guys, it is the 16th of September, 2020, and we are going into hyperinflation, RT210J. This is a live lecture for RT210J, which is J. Hyperinflation and obstructive versus restrictive disease. All right, so we're going to jump right in. I don't have anybody live. Nobody's in the class, but I'm going to go ahead and get started. Let me share my screen. The PowerPoint, this PowerPoint and the note-taking guides all can be found in the module. Okay. The homework for tonight has already been established and has been put into your Canvas. You have homework number 1 is due tonight by midnight. It's been active ever since about 8 or 9 o'clock this morning. I put it in this morning so you can get it done by midnight for your attendance today. This is the last unit exam, and I encourage you guys to really take this serious. This is the last one. If you haven't been taking it serious, which many of you have, but some of you have not, and it shows in your grade, okay? All of the grades have been put into the system up until this point. Those of you that asked me about your grade, I told you what you had. We kind of played with some numbers to see where you need to be in order to graduate. Past 210, okay? Don't forget those lab days that I gave you in the module, as far as email and the makeup days. I told you some makeup days. If you got labs you need to make up, it's your responsibility to let me say, okay, on this makeup day and that makeup day, Mr. McCarthy, I want to come in and do this, this, and this if I can, right? I can't go around and search everybody and say, okay, you're missing this one, you're missing that one. What can you? I'm not doing all of that. Okay, it's your responsibility. You have the syllabus. You know what the pages that are in the lab book. You are aware of all of the labs that you have done and the ones that you haven't. Okay, if Mr. Boyd did one of your labs and you didn't get it signed, you'll need to get it signed by him. I will not sign a lab that he did. Okay, and vice versa. He won't sign his name to a lab that I did that you did not get signed. Okay, so with that being said, this is the hyperinflation therapy. We've gone over all of the things and the basic foundations of respiratory. And we talked about the anatomy of the heart. We talked about the anatomy of the lungs. And you have to excuse me, I got allergies and my eyes really bother me, so I may cut the camera off at times. But we've gone over the pharmacology of the airway. We talked about aerosol and humidity. We talked about gas physics and how they pertain to the human body. We've talked about ABGs, respiratory chemistry, right? Gas chemistry, blood chemistry, CO2's transport, oxygen's transport throughout the system, and whether the body is in an acidosis situation or an alkalosis situation. And then, of course, on your coming up oral and final, you will have several ABGs, okay? I had tutoring yesterday from 10 to 12. Nobody showed up for tutoring. So those are the kind of things that follow you. If you don't pass and it shows that, well, you never came to tutoring, some of your homeworks you didn't turn in, those are kind of things that will, don't work in your favor, okay? I think that through this course, we've gone through COVID-19. We've become very, very flexible for the student. As far as makeup tests, when you had to make up a test, you had well more than the time that you're supposed to have for making up the exams. Not being able to come to class, but you can watch the recording, right? All those kind of things which we did not do last term. But because of COVID, we're having to turn that page and go more toward a hybrid type of situation. And speaking of that hybrid situation, on the days that you were given for your labs, many people don't come to the labs. Okay, and so I'm telling you, there's no way that we can make up all of your labs on one day. You have to make adjustments or arrangements for school, just like you have to do your children and your job. Okay, like I said, we've been very, very flexible, and for the most part, you guys have worked hard and made sacrifices. Some students try their best to come up here more often. Doing everything that you can be, because this is your education. Right? And we're trying to put out quality respiratory therapists. At no point will you get to a place where we're just pushing students through. All right, you have to take onus and responsibility for your education. All right, so this is it. You got this one. You have CPR exam, which is open book, so you should get 100 on that one. And then you have your oral and final. Okay. The final is very, very heavy. You can go into the final passing, but if you don't pass or do well on the final, it can bring you down. Or if you're not doing so hot and then you hit that final and do well on it, it can bring you up really good, okay? It's 26% of your grade. Oral is 16% of your grade, okay? So if you are in a 60, if you have a 60 average or 50 average at this point, then this coming up for is really nothing you can do to get to a 75. You have to have been going and trying your best throughout the program, okay? Again, if you have to repeat this class, next course will be from 8 to 1, okay? It will be from 8 o'clock a.m. to 1 p.m., all right? And I will be doing my daily lectures, and you will have to either watch them, be live, or come into the campus, all right? Don't forget those lab days. They will be a little bit different for the next course. We're going to have certain days will be just a lab day, okay? Trying to transition into this new model that Concord's trying to accomplish, okay? A new model of purely hybrid. So you may not be on campus only to do your checkoff, okay? So we'll see how that works. All right, hyperinflation. Again, once we have drained the lungs, once we have wet the lungs with dilutants and mucokinetic drugs, we have dilated the lungs with sympathomimetic dilators. We have blocked the effects of acetylcholine in our parasympatholytic drugs, also known as anticholinergic drugs. And then sometimes we still have atelectasis. Sometimes we're still dealing with the lungs being closed in pockets, right? That's atelectasis. We talked about how oxygen, too much of it, can cause absorption atelectasis, right? And we talked about what it is when those alveoli are closed. So recap, when the alveoli is closed, but there's a lot of perfusion, then that's a shunt, right? That's a shunt. And a lot of times atelectasis can lead to shunting, which is blood leaving the right side of the heart and returning to the left side of the heart without picking up vital oxygen. That is a right to left shunt because the alveoli is closed, right? Now, if the alveoli is open and we have perfusion, then we have a normal unit, right? And that means we ventilate well and we perfuse well to get a normal ventilation to perfusion ratio. Well, sometimes we have patients who don't take deep breaths, right? Can you think of some times that you might have not wanted to breathe deeply, right? Maybe you had surgery in your upper abdomen area, or you had a wound in your ribs, or you fell and broke a rib, car accident, right? Sometimes neuromuscular issues can cause people not to be able to take a very deep breath, right? So if you're not ventilating well, then your alveoli will start to close, right? And so we think about those who have sedation. What about when you're going into surgery and you're about to be sedated? Well, when you come out of surgery, you may have some atelectasis because of the sedation, okay? And so in that case, we have devices that help hyperinflate the lungs, like blowing up a balloon, right? But instead, we have two ways to do it. It can be natural, which is negative inspiration, you just taking a deep breath, and we have machines or devices that measure that breath from a natural perspective. And then we have some unnatural ways to hyperinflate you, and that will be giving you positive pressure, right? That will be including positive pressure into the patient's lungs, forcing them to open up or forcing them to ventilate, all right? So today we're going to talk about some of the basics of hyperinflation. What are the indications of hyperinflation, and what are the differences between natural or unnatural modes of inflation therapy. Okay, all right. This is a picture of some healthy lungs. This is a picture of some healthy lungs that come out of a cadaver human that donated his or her body to science. You see that they are nice and fleshy, pink. They don't have any black spots in them. If this had been a smoker's lung, it would be black, right? It would be brown and black looking with some bronchiectasis and some bronchiolitis, all kind of nastiness, right? Because of smoking, okay? But this is evidently a non-smoking adult who has beautiful lungs, right? But we want to hyperinflate. So your objectives, student will be able to safely administer lung inflation procedures because we don't want to overdo it, right? You can overinflate the lungs and cause issues as well. Pop a lung, which is a pneumothorax, or you can stretch them too far and tear them, which is called barrel trauma, okay? And so we're going to be looking at ways to properly do this to accomplish a state of no atelectasis, but at the same time not to overdo it or damage the lung, right? You're able to describe the effects of positive pressure breathing. PPB is positive pressure breathing. That's when we are pushing in some volume, right? Positive pressure into the lungs to help you ventilate. Back in the day, we used to use a machine called the IPPB machine, which is intermittent positive pressure breathing. They have since gone away with that machine, which was the Bird ventilator and the Bennett PR2. We don't hardly use those anymore, and that's not on your board exam anymore. So we're just going to focus on positive pressure, just pushing some positive pressure into the lungs. And we're going to learn that how we start a breath, what the term means to start a breath, and what the term means to end a breath, okay? We're going to have to know that dynamic as we progress, okay? Describe the indications. Why would I use PPB? Describe the hazards of PPB, right? Describe the setup and instruction and coaching, because this is a passive job, right? The patient, all he has to do is trigger a breath and the machine will do the rest. But it's going to force some air into their lungs. So you're going to have to tell Mr. Johnson, all right, relax, Mr. Johnson, because he may back up off of it like, what is that, right? It may startle your patient. So it's very important what to look for and how to coach them, whether your therapy is being therapeutic or if it's harming the patient with some negative adverse reactions. Demonstrate ability to set up any kind of positive pressure device that you may see, which now is mostly some type of CPAP machine, a BiPAP machine, or the Metanel, okay, the Metanel. All right, the first way of hyperinflating would be the IS or Incentive Spirometry, okay? IS is Incentive Spirometry, also known as sustained maximal inhalation, okay? This is a natural way of hyperinflating because we use the negative pressure. Negative pressure is when you're sucking in and your body, your insides are becoming more negative, right? Your intrapleural pressure is becoming more negative than the ambient pressure. Therefore, the air flows into the lungs, which is natural, okay? So what would be the reasons we would use incentive spirometry? All right, well, the main thing is to improve atelectasis, to prevent atelectasis, and when we say prevent atelectasis, it would be somebody that's going into surgery. Say Mr. Johnson is going in for upper abdominal surgery, right? So that means he's having an incision that is very close to his diaphragm. The closer to the diaphragm the incision, the more weak a patient will be in breathing coming out later. So you have a higher instance of possible atelectasis with someone who has an incision that's close to the diaphragm, because we know that the diaphragm is innervated by the phrenic nerve, left and right phrenic nerve, and when they do, the diaphragm descends. That draws the lungs open, right? Well, when that happens, that's natural breathing. But if I get a cut or an incision, or I have some type of surgery that's going to injure me or cut me higher up on my abdominal cavity, then that's going to be close to the diaphragm, and it's going to hurt for me to breathe, all right? And the more that the patient hurts, the less breath they're going to take. And as that progresses, they become atelectic, right? So post-op, when somebody's coming out of surgery, what are they? What happens when you go to surgery? What do they give you? They give you sedation, right? And so if you're sedated and real druggy, you're not taking large breaths. So that, in that case, you can develop atelectasis if you're not careful, or if we don't explain or instruct them how to deep breathe before they go to surgery, right? Mr. Johnson's on his way to get upper abdominal surgery. He may have some comorbidities that will even more affect his atelectasis status, like COPD, obesity, right? Smoking history, bad cough or infection. When that happens, when he goes down under the knife, when he comes back, anything that would have been naturally an effect may be 10 times worse because of his poor comorbidities, all right? So you have to know your patient and explain to him, hey, I want you to do this incentive spirometry, learn how to do it so that when he comes out of surgery, you're not trying to wave something in his face to teach him. You already taught him before he went to surgery. Therefore, when he comes out, he wakes up a little bit, he can go right at hyperinflation therapy. So to improve atelectasis, to prevent atelectasis, which is post-op patients, some of your COPD patients, or other pulmonary complications, right? Patients that have other pulmonary issues. The next reason would be to mobilize secretions, right? In order to get a good cough, we have to have a viable vital capacity, right? When you cough, you don't just, right? You have to take a deep breath in and cough, 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 right? Well, everything that you can do is your what? Vital capacity. Much as you take in and as much as you can blow out. So if your lungs are suffering from atelectasis, then your vital capacity numbers will be low because the alveoli are closed, right? And so if they're closed, they collect more secretions and you don't expel them, okay? So if we want to improve or move secretions, we can make sure that those lungs are good and inflating so that when you do take that nice breath in and cough, it's going to force out those secretions. So to improve atelectasis, prevent atelectasis, and to mobilize secretions. Those are the three reasons why we give incentive spirometer, okay? This here is a picture of the incentive spirometer. I'm sure many of you have seen before, usually on the patient's bedside table or next to the patient. The farther away from the patient it is, the less they're doing it, okay? The closer it is to your patient, you know he or she is doing it, all right? This has also been considered the ticket out of the hospital. Incentive spirometry has been known to be the ticket out of the hospital because atelectasis will lead to several other things like domino effect. Just like having insufficient humidity can lead to a domino effect causing pneumonia and possibly death, right? But once you start dropping, you drop fast, especially in our young kids, right? When they drop fast. So in order to ensure that your lungs are working well, because your lungs also provide your what? Your oxygen. They provide your adequate CO2 clearance, right? If my lungs are not working, I'm building up CO2. My oxygenation is a problem, right? All of these things can cause a problem if I'm not ventilating, right? So incentive spirometry, the natural way of hyperinflation, uses a negative force, right? You're sucking in, natural, negative, right? Remember that, natural, negative, right? Negative inspiration is the natural way that we breathe. So if you look at this young man here, he has one in his hand. There are several different types of incentive spirometry. The one that you'll see the most in the hospital will be this one, okay? This one here will be the one that you see the most. We also have some here that we give the students that come, and when you come to lab, we'll, if we have them on deck, we will give you one to take with you. But basically, you have the place here. This is the goal marker or incentive, right? This is your incentive to get out the hospital, right? So they call it an incentive spirometry. Also, the number, which is the volume, right, in milliliters, is set by your patient's age and his height. When you open up one of these incentive spirometries, they will have a chart, and it gives you male on the top, female at the bottom, and it tells you the age on the side, and then the height across the top in inches. All right, so for instance, if somebody is 5 feet, they are 60 inches. If they are 5'5", they are 65 inches, right? So whatever height you are, you go to your age and then go over to the height, and whatever volume is there in that cross path is your volume that you should be able to do. Remember, we always said it's not about your weight, it's about how tall the lungs are. The anatomical length of the lungs mean how much volume should be in those lungs. Okay, so somebody who is 7 feet tall but only weigh 90 pounds, he's still going to have a larger tidal volume than somebody who is 4 feet tall and 700 pounds. Okay, doesn't matter about the weight per se. It's mostly about the length. So you have the goal marker here. Then you have what's called the piston that rises when you inhale, right? You're going to inhale through the mouthpiece, not blow in. You suck in, but you take a slow, deep breath with an inspiratory what? Hold. What we always said, the same technique that this guy here is doing. You put it in your mouth and you take a slow, deep breath in, okay? As you breathe in, this thing here is a float or a flow detector. Okay, you see it right here on this one. It's over here behind the mouthpiece on here. You see that little with the 2 arrows, and then over here you have this little nice one for kids, right? It's this float here. It's going to float in between here. That tells me that I am doing a slow breath with a slow deep breath with an inspiratory hold. If I am doing it too fast, then that float will shoot up to the top. That's not what we want. We don't care if he can do it hard. We want him to be able to do it slow and deep, okay? So slow and deep. If you do it slow and deep, the indicator will remain in between the arrows, right? This little indicator will remain right here, will just float right there. As that floats, your bellows or your piston will rise to your volume, all right? And so naturally, a lot of times patients don't get to their volume for the very first time, so that's why we call it an incentive, right? If you're supposed to do 2,000 or 2,500, we set it there. And so the patient will work on it about 10 times an hour until he or she meets his goal. When you meet your goal, you're good. That means all of your lungs are open, okay? If you can't meet your goal, that means you're suffering from either pain or atelectasis. Okay, so we can prevent atelectasis by using this, and we can treat atelectasis by moving this, and we can move secretions by using this. Okay, let me find my mask. Hold on 1 second. This is Jay. All right. Notice down here, this is for a child. That's why it has all of the nice little colors and stuff on it for a child. All right. This is incentive spirometry, which uses sustained maximal inhalation, right? Also known as a slow vital capacity, right? Except you're not going to exhale through it. You're just going to inhale only. Slow, deep with an inspiratory hold, and it's used to prevent atelectasis, treat atelectasis, and mobilize secretions. All right, like everything, it has some contraindications, right? Some reasons why you would not use incentive spirometry. Well, if the patient can't cooperate, then it's not going to work. It has to be properly taught. It has to be properly used in order to get the proper therapeutic results. If you tell a patient to inhale slow and deep with an inspiratory hold and he or she keeps blowing in it and refuses to inhale, then I'm just going to put it to the side. We're not going to be able to do it, right? You have to be able to understand it. So someone who is mentally challenged or someone who is very, very old or very, very young may not benefit from this because they can't cooperate. Or if you have somebody who is sedated, if somebody's in a coma, you can't put this up to somebody's face and say, take a breath, right? So those would be some reasons why you couldn't do it, right? So unable to cooperate. That's the first contraindication. Unable to follow instructions. So if they can't cooperate, but they just can't seem to put one foot in front of the other, right? You tell them all of what to do, but they just can't seem to get it right, right? That's somebody you can't use it for. Again, if they're unconscious, right? Unable to take deep breaths. Again, if you just had surgery, you're going to try your best to take those deep breaths, but sometimes they just can't take deep breaths. It may be from a restrictive disease. You're going to learn a little bit later in this very unit that we have obstructive diseases and we have restrictive diseases. You learn that obstructive diseases, patients cannot get the air out. Well, restrictive diseases mean they can't get it in, okay? And that could be from a variety of pulmonary issues or skeletal issues, right? If somebody has scoliosis, that's the curvature of the spine, right? If somebody has kyphosis, that's hunchback, and they're all always like this. Or if they have both, kyphoscoliosis, where they're toothless and bent over. In those cases, the lungs are kind of compressed. The rib cage is kind of distorted, so the lungs can't inflate. They can only inflate what the ribs allow them to do, okay? And so if you have a restrictive disease like that, that may limit the amount of air that you can take in, and that's called a restriction, right? If you restrict somebody from something, that means they can't get in, right? If the door has restrictions on it, then only certain people can get in. Well, if our rib cage has a skeletal dysfunction, then it limits the amount of air that the ribs can take in, okay? And not only that, you're going to learn other types of restrictive diseases, right? What are the hazards? Once I decide to do IS, then there are some hazards I have to look for, okay? Some hazards. If you just think about some things before we even go forward, just think about what's possibly could be some hazards of forcing somebody to take a deep breath, right? Them taking in a deep breath. What happens if you sit here and just take a bunch of real deep breaths real fast? What's going to happen to you? You're probably going to experience a little bit of lightheadedness, right? Because you're blowing out too much CO2, right? So hyperventilation will be a hazard, right? That's why you have to coach them correctly. Slow down, Mr. Johnson. You don't have to do it 10 times right back to back. Slow, deep breath, inspiratory hold, pause for a minute. Do it again, pause for a minute, right? Make sure that they're keeping a good balance. So the hazards are it's ineffective if you don't do it right. That's just like one of the contraindications. Hyperventilation. Hyperventilation causes hypocapnia or hypocarbia. Remember that. Carbia, capnia are CO2, and CO2 is ventilation. So if you're hyperventilating, you're blowing out too much CO2. That can cause dizziness, lightheadedness, or fainting. Barotrauma. That's when you stretch the lung and you kind of scarred a little bit, right? When you put a little scar on the lung, you overstretch the lung. That's called barotrauma. Barotrauma. Discomfort, secondary to pain. Okay, secondary to pain. If they're already hurting, say they got had a back surgery or some type of surgery that's already causing them to hurt, well then it could be discomforting doing these deep inspirations because they already have pain. Okay, in that case, you might want to see if you can correspond your therapy with your nurse and see if the nurse can maybe give them a little something before you do this therapy, right? Not something that's going to completely knock them out, but just something to take the edge off before you get started. That's how you converse or you team up with the rest of your healthcare team, right? Give them a little pain med, a little Tylenol or something that's going to keep them focused, but not in so much pain. Fatigue. If they do it over and over again, they're going to get tired. Okay, you can tire out. especially if they have some type of heart issue. If you have some type of heart disease or some type of heart issue going on, whether your stroke volume or your heart is not where it should be, right? Cardiac output should be 5 liters per minute. If you're down to like 3, then you're going to have a low stroke volume, okay? And that's seen in a echogram, right? A cardiac echo. And they can see if your heart is functioning at what percent that it should be. If they have somebody, your patient has a low percentage, then you know that they're probably going to get tired. You have to be careful with them because breathing hard will make them tire out. They'll be tired really very quick from heart issues. All right, so what's the procedure? Like everything else we said, don't forget this. Slow, deep inspiration with an inspiratory hold. That's very, very important. That's how you coach your patient to do incentive spirometry. Then they say relaxed exhalation. It's not a deep breath in and then blow it out. It's just a deep, deep, deep in, hold it and let go, right? The lungs automatically exhale because of elasticity, right? The diaphragm ascends and the lungs retract. The rib cage comes in, right? All of that is passive. It's relaxed. You don't have to force yourself to exhale unless you have COPD. Because if you have COPD, you have lost that elasticness or elasticity of your lungs, and you cannot exhale like everybody else. Okay? So you tell them, slow, deep breath in, Mr. Johnson. Hold it for a minute now, let go. And then just let it go. They don't have to blow back through the machine. All right, the volume of that gas move should be the inspiratory capacity, right? So when they take a breath, in, that's your inspiratory capacity, right? Inspiratory capacity is the air that you can breathe in after a normal exhalation. So after a normal exhale, you breathe in tidal volume and IRV. Both of those together is your inspiratory capacity. So after he exhales normal, you tell him, okay, take a breath, and it goes in. He keep on breathing past tidal volume into his IRV, and then he just lets go. So the volume of gas moved during incentive spirometry is inspiratory capacity, right? Which again is the maximum inhalation following a quiet exhalation. Don't forget that. When we have our oral exam, they're going to be asking you about pulmonary mechanics, IRV, ERV, tidal volume, TLC, FRC. Those questions will be rampant on your final and in your oral, as well as ABGs, right? Total flows. That is the last way to make sure the student has what it takes to get to 220, okay? So a lot of this other stuff that you learn and you did well on, if you don't know ABGs, if you don't know your pulmonary mechanics, your pulmonary anatomy with your segments, right? It's going to be hard to get to 220. It's going to be hard unless you just have a photographic memory. You have to study it and you have to understand it. So go back to that spirogram and learn those different things, those volumes and those capacities, because you will see them very soon. Right after this week, you go into your orals. You know, all week is one day. All right, procedure. Coaching the patient is important, right? Coaching the patient is important. Encourage them. Come on, come on, come on. When you go to a hospital, you may hear the PFT lab. If you walk by the PFT lab, which is the pulmonary function testing lab, okay, you're going to hear the respiratory therapist in there being encouraging, right? You may say, okay, take a deep breath in, keep on, keep on, keep on, keep on, keep on, keep on, now, blow, 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 keep going, keep going, keep going, all the way, all the way, all the way. All of that cheering, you will hear that in the PFT lab. If you're one that's timid and quiet and you can't do that, then the PFT lab is not for you, okay? It's not for you. You have to encourage that patient to take those different breathing exercises so that your reading on your computer is accurate. Because once you get that PFT, you're going to print it off and send it to the pulmonologist. That's how we know, as respiratory therapists, how to deal with your situation. We got to first know where you are, right? How much or how bad or what stage are you in your pulmonary issue, so we'll know where to start to help you. All right. So a PFT is very important. This is like a incentive spirometry is like a bedside PFT. Okay. You should be just as encouraging when you're getting them to inhale. You got to ensure proper technique, right? Make sure they're holding it right. They got their mouth sealed around the mouthpiece right. Breathing in slow and deep. All those things are important. Now the frequency. The frequency may be performed after patient instruction, right? So once you instruct them how to do it and you watch them do it, then they can do it on their own, okay? We will come by, like depending on what hospital you are, you may come by once or twice a day just to see them do it, right? But while you're not there, you'll tell them, hey, Mr. Johnson, I want you to do this every hour while you're awake till you get to your goal, okay? So usually we used to tell them, you know, when a commercial comes on, knock it out for 10, 11 times. You're watching TV, commercial comes on, grab your IS and practice, right? But at least every hour while awake, okay? And then when you come around, you'll watch them do it and see where they are, and you'll chart it in your chart, okay? Once they have met their goal, you can just kind of ease back from going to see them and just chart that the patient met his goal, but you will continue to encourage him or her to continue to do it because this is the ticket out of the hospital. So again, once he meets his volume, then you just follow up daily or PRN. The equipment we use, most actually measure the flow and the time, and that's called the tri-flow. So we talk about different incentive spirometers. The tri-flow is an instrument spirometer that kind of measures the flow and the time, okay? But the one you're gonna see the most will be the one that measures the volume, okay? So the one that measures the flow and time is the tri-flow or the Inspirx. I have not seen those in the hospital. Every hospital I've been at is the one that measures the actual volume that I showed you in that first picture, where the bellows goes up, right? And it measures the volume, okay? And that one is mainly called the Bartlett Edwards, right? Uses the bellows. That's the one you usually see, or the Valdine, right? You may see, they got so many new ones that come out all the time, but basically the ones that measure the volume are the ones that we see mostly, okay? Also the Inspiron. All right, evaluation of your patient. Remember, patient evaluation or patient assessment. Assessment. You're always looking. Does he look like he's about to pass out? What is his heart rate? What is his SAT over there? Is he breathing symmetrically? Like one side of his chest is not rising and the other one's not. That's a problem. You need to stop. Is it hurting him? Is he telling you or she's telling you that I'm lightheaded or dizzy? My fingers are tingling, right? All those things you're looking for. You're looking. As you do any kind of therapy with your patient, you have to assess. Okay? And you will assess before and after the treatment, okay? You always assess before and after the treatment to see if your treatment improves. So you may do breath sounds, right? You may listen to him and he's diminished, right? It's normal, but it's real low. You barely can hear it. Then you do IS, right? And then you listen and there they are. Breath sounds are nice and full because that means you have improved his atelectasis. So the patient must be alert, right? Got to be somebody that's alert. They have to be cooperative. Got to be able to physically increase their IC greater than their tidal volume. So what they're saying, they got to get to inspiratory capacity. If they can't do that on their own, then it's not going to work for them. Okay, you got to be able to increase their inspiratory capacity greater than just tidal volume. Remember, tidal volume is just in and out, regular quiet in, regular quiet out. That's not hyperinflation. They have to be able to go above that. If they can't go above that, then they can't use IS. Okay, we'll have to do something else, which we're going to learn in a minute. Okay. It says the volume that they move should be 3 times the predicted tidal volume. So what they want the patient to do is to be able to do at least 3 times their predicted tidal volume. So if their predicted tidal volume is 500, then they want them to be able to at least move 1,500 on the incentive spirometry. Okay, they want them to be able to move at least 1,500 on the incentive spirometry. So 3 times their predicted tidal volume. So whatever their predicted tidal volume is, times 3, that's about where you want them to be. Now that's without looking at the chart, right? If you don't have that chart and all you know is the patient's weight or whatever to get the way you predicted their tidal volume, then you just use that. Predicted tidal volume times 3 and set the little goal marker around whatever that is. All right. If the patient is not able to do those things, not able to take a deep breath, not able to get their inspiratory capacity, right, about 3 times their tidal volume, if they cannot do that on their own, which is natural, right, negative is natural. Natural way to do it, slow, deep with an inspiratory hold is natural. If they cannot do that, then we have to go to unnatural, which is positive pressure breathing. That's when you force air into the patient's lung to hyperinflate them. Okay. On that note, we're going to take a 10-minute break. It is 1:40. I'm going to pause the recording to 1:50 and pick back up. All right, guys. Break is over. We're back. We just got through talking about incentive spirometry, and I showed you a picture of it, talked about it a bit, and now I said, when you get to the point where incentive spirometry or the natural way of hyperinflating the lungs does not work, whether they can't cooperate, they're hurting, they're sedated, they can't get the breath in from a restriction or whatever the problem is, then we have to go into what's called positive pressure breathing or intermittent positive pressure breathing, and to the point where the patient will trigger a breath and the machine will deliver a set volume or pressure, right? Deliver a set pressure into the lungs, and when that pressure is met, it stops, okay? So when I told you you're going to learn about those terms are called trigger and cycle. Trigger means to start inspiration, and cycle means to end inspiration, okay? And so before we get into those details, we want to show you a few things about the incentive spirometry. I have one here, and this is the paper here, okay? Notice how it has the male or the female on top and the male at the bottom. It has the age on the side and the height across the top, okay? That will determine how much flow that you should have, okay? How much volume the patient should be able to achieve, okay? So in that case, we would have, let's say for instance, I'll circle it. All right, let me pin my video. Okay, so if you have that, this is what you have. I'm going to say, for instance, I have a 5-foot female who is 30 years old, okay? So I'm going to go over to 30, down to 30 years old, and go over to 60 inches. I'm going to circle that for you, and you'll see it. A 60-inch female who is 30 years old should be able to produce at least 2,000 mLs on the incentive spirometer, okay? What about if I have a male that is 5'6", right? 5'6" would be 66 inches because 60 inches is 5 feet. 5 feet is 60 inches. So 6 more inches on that will be 66 inches. So I'll go over to 66 inches, go down to a 30-year-old, and he should be able to pull 2,700. Okay, that's how you find it. So once you find your volume that you should be doing, so let's look at the lady, 60 inches at 30 years old. So if I know that Miss Johnson is 30 years old and she's 5 feet tall, then I will get her Incentive Spirometry. Took it out the pack, right? And I have the actual device here, okay? And I have the mouthpiece and tubing. I simply put the tubing on here like this, right? And I make the patient inhale, okay? I would then set the goal marker to, what did I say, 2,000. So about right there. That's 2,000, right? Up just a little touch. And that's all I expect from her, okay? She may be able to do more, but I only expect her to do 2,000, okay? That is what she's supposed to have in her lungs, okay? Because you don't want to overdo it, because overdoing it, we said, can cause barrel trauma. Now, again, let's look at the other part, the flow marker. See how that moves freely? That is going to determine whether I am breathing in slow and deep enough. It says best, better, good. See how the good is at the top? That's because if I suck in too fast, it's going to shoot up to good. That's good. We want slow, deep with an inspiratory hold. So the slower I do it, the more it's going to hang right here between best and better. As that hangs there, the bellows, which is the white part, will then raise up to my volume that I achieve, okay? We have one of these for every student if you want one. Okay, so for instance, if I was her, I'm trying to get to 2,000. So I'm going to do it from the back here so you can kind of see everything move. Watch as I see how that flow detector move. That's not what we want. We want a slow, deep inspiration. So watch the marker, this one, as I inhale. Let it out. See that? Notice how I kept the marker in the best or better section. That ensures that the patient is breathing a slow, deep inspiration. And when I did that, my bellows went up to a certain amount. I didn't catch that. So now I'm going to watch the bellows and see what I make it to. So I'll just blow my air out. Regular exhale, remember, vital capacity or inspiratory capacity, I'm sorry, is the maximum air you can move after a quiet exhalation. So quiet exhalation is this. Now I'm going to go from there. See, I got to about 3,000, okay? So you would mark that wherever you're supposed to be, and you keep on doing it. When somebody is hurting or sedated, then they're probably going to be like, oh, that hurts. That's all I can do, right? And that's okay. But we're going to keep the goal marker where they should be. And if they practice it, and practice it, you will start to pop open those alveoli, and they would then be able to meet their goal, okay? Just put that in there just like that. Let that sit on their side of the bed at the bedside table. Keep it close. Again, if I get to the room and they are not, that's not anywhere near them, right? Then I know they're not practicing. Either they met their goal and they stopped, or they just said, I ain't doing that, okay? You have people who have compliance issues that won't do what you ask them to do, and that is your ticket out of the hospital, okay? So again, as we said, if that doesn't work, the patient for some reason is mentally challenged, very, very old or young, or just can't seem to understand, either sedated, obtunded, anything like that, right? You can't do this. So we have to go then to the big guns, which is the positive pressure hyperinflation. And that's when you have all of your things you got to worry about because it's not natural. Negative, which is this is negative, right? When you're sucking in, becoming more negative, that's natural. But positive, when I start forcing air into your lungs, that's not natural. And I have a lot of things I have to look out for and watch out for because that's not natural. All right, so let me go back to sharing my screen to the PowerPoint. IPBB indications, primary indications. All right. What are the primary indications? That means the primary reason I use positive pressure breathing and not negative pressure, which was natural. Okay. Well, patient does not have an adequate vital capacity to facilitate a cough. We said that a cough needs a great vital capacity. When you cough, you do this, right? You have to take a deep breath in and then force everything out. That's a cough. That's a vital capacity, right? Same thing as a cough. And if you can't seem to muster up a good vital capacity, you can't get a good cough. If you can't get a good cough, then you are retaining secretions. If you retain those secretions, then you have a lower oxygen saturation and the chance that those secretions can set up infection and become pneumonia. So you see how important it is to get that cough out of there, to get those secretions out of there, right? That's why we talk so much about the medicines on the last exam. We talked about mucokinetics and how they break down that mucus, because that mucus can overwhelm you and choke you out if you don't get it out of there, okay? And so that is very, very important. So the primary reason is because that vital capacity was not enough to facilitate a cough. Because if it was, they could use Incentive Spirometry, right? If they could breathe in real good, then why? I don't need positive pressure. They can use the negative because they're doing it already, right? So since they cannot do that and facilitate a good cough, then I'm going with positive pressure. And that will mean that their vital capacity is less than 3 times predicted tidal volume, right? So that you wouldn't probably count that, have to count that. Just know that if they're trying to do a vital capacity and that volume that they're moving with the vital capacity is not enough or not even 3 times their predicted tidal volume, then you're going to have to run with positive pressure. And the only way to know what their vital capacity is to have a bedside spirometry where you would tell them to take a deep breath in and blow it all out. And you can measure that, right? But 9 times out of 10, you won't have that at your disposal, right? The department may have a little bedside spirometer, and you'll learn more about that as you go on in respiratory, okay? But just know the primary reason, they don't have a good enough vital capacity to facilitate a cough, and that would be a vital capacity that's less than 3 times predicted tidal volume, right? Another way to understand the vital capacity is less than 3 times predicted tidal volume is just to simply say their vital capacity is less than 15 milliliters per kilogram of ideal body weight, okay? So if it's less than 15 milliliters per kilogram, then you need positive pressure. So let's look at an example. An example of that. If I said that Mr. Johnson weighs 88 kilograms, okay? Mr. Johnson weighs 88 kilograms. I'm going to give you his kilograms, and I'm going to give you his vital capacity. We're going to answer whether we got to do positive pressure or we can do regular negative pressure, which is natural, right? Remember, to use natural weight, it has to be greater than 15, right? If I have to use positive pressure, that means his vital capacity was less than 15 mL per kilogram of ideal body weight, right? So the first one I said, Mr. Johnson is 88 kilograms, okay? He's 88 kilograms, and I told you that his vital capacity was 1,000 cc's. If his vital capacity was 1,000 cc's, then would I use positive pressure for him or would I have to use negative pressure for him? Look at that for a moment and let me know. All right. I said his weight was 88 kilograms. And I said we have to use positive pressure if his vital capacity is less than 15 milliliters per kilogram of his ideal body weight. And I told you that his vital capacity that he was showing me is 1,000 cc's. Okay, so in order to do that, you know that he's 1,000 cc's. You do 15 times 88, right? 15 mLs per kilogram. So 15 times 88 is 1,320 cc's. Okay, that's what his vital capacity is. All right. Now, so in that case, I need to use what? Positive pressure, because all he pushing is 1,000. All he can do is 1,000, but he weighs 88 kilograms, so he should be doing 1,320, right? But he's only doing 1,000. So if all he can do is 1,000, I need to use positive pressure to force that 1,320 into his lungs. Okay, so you may have a problem like that. So make sure you realize that and kind of play with that. Okay, let's do one more. Mr. Smith is 79 kilograms, and his vital capacity is 1,450. He's 79 kilograms, and his vital capacity, when I tested his vital capacity, it was 1,450, 1,450. So then I need to know which one would I use, IS or positive pressure. His weight is 79 kilograms. 79 kilograms, and his vital capacity was 1,450. So for this one, he's 79 kilograms. He's 79 kilograms, right? And we want to see is his vital capacity more than or less than 15 mLs per kilogram. So he is 79 kilograms, okay? And his, I told you his vital capacity was 1,450. Well, at 79 kilograms, he should be able to do 1,185, but he's able to do 1,450. So he's above that. So since he's above 15 milliliters per kilogram, we can use the natural way, which is incentive spirometry, okay? We're looking at the indications for positive, so don't let that confuse you guys. Positive pressure indications. That means if he has a vital capacity, which is less than 15 mLs per kilogram, then you have to use positive pressure. Well, the one we just did was 79 kilograms, and his vital capacity was 1,450. Well, 15 times 79 is 1,185, so he's above what he should be. So since he's above that, we don't have to use positive pressure. We don't have to force it because he can already what? Do it. All right, he can already do it. So that's the indication of why I need to use positive pressure breathing on somebody, okay? That's the indication. All right, indication secondary, right? That's the primary indication, just simply because they can't facilitate a cough, right? They don't have enough vital capacity to facilitate a cough. And if I want to know, well, what vital capacity is that? I mean, how do I know if it's enough or not? You can simply say a vital capacity less than 15 milliliters per kilogram. If it's that, then you have to use positive pressure. If it's greater than that, you don't have to, okay? Secondary indication. What would be a secondary reason? To deliver medicine. With the incentive spirometry, you cannot deliver medicine. Now, being a respiratory therapist, you can figure out a way to put it in line, but technically, by the book, it's not able to deliver medication. But our positive pressure devices can deliver medication, right? So not only are you doing hyperinflation, but you're also able to give him medicine at the same time, right? So you think about it. If you have a patient, Mr. Johnson, and the doctor has ordered hyperinflation and he has a Q6 breathing treatment, right? You're not going to want to go in there and do hyperinflation with the IS. Say he has a good vital capacity and everything, right? You don't want to go in there with an IS and let him do that for a little while and then turn around and give him a breathing treatment and watch him do that. That's going to spend all your time in that one room, right? You want to knock out two birds with one stone, use the positive pressure modality, which will give him hyperinflation as well as pumping medicine in at the same time, right? That's why we use the meta-nav, right? The meta-nav does three things in once. It hyperinflates, it CPTs, and it delivers medication, all in one treatment. So instead of being in there 30 minutes, you're in there 10 minutes, okay? Because you usually do 10 minutes per treatment, 10-minute breathing treatment, 10-minute hyperinflation, 10-minute CPT. But if I have a meta-nav, I can do all three of those things in 10 minutes, right? One 10-minute session, I'm out, okay? So to deliver medication, so if your patient does qualify for incentive spirometry, say they do have a good vital capacity, right? Nothing wrong with them. But the doctor also wants them to get medicine. In order to bide your time better and to have better time management, I will use the positive pressure modality because I can do two things at once, okay? So to deliver medication would be the first secondary indication. To improve the IE ratio is another secondary indication. Improve the cough and mobilize secretions because yes, incentive spirometry will help you mobilize secretions, but positive pressure will do it better, okay? Positive pressure will do it better. Alter your VQ, right? If your VQ ratio is off, positive pressure will alter that because I'm pushing volume into your lungs, right? So if I'm pushing volume into your lungs, which one of the VQ am I altering? If I'm pushing pressure and volume into your lungs, air into your lungs, which part of the ratio am I affecting, the V or the Q? By putting in more air. The Q is the blood flow. I'm not pushing in blood, I'm pushing in air. So it's the V, right? Ventilation to perfusion. VQ is ventilation to perfusion. So if I'm pushing more ventilation into you, then I can affect or alter the ventilation part. Remember we said the normal VQ is about 4 to 5, right? That's the normal VQ, 4 liters per minute of alveolar minute ventilation to 5 liters per minute of cardiac output. You guys got to know that. That's the normal VQ. So that's why we said, as we took notes, make sure you have a formulas page, a terminology page. Every time you learn something new or a new formula or something, you put it in on that page so it's not hard to find. So your VQ, your minute ventilation, your alveolar minute ventilation, all those things should be somewhere together that you can go back and study together instead of flipping through all of these sections, okay? We told y'all how to do that from the start. So secondary indications for PPV, deliver medication, improve the IE ratio, improve cough and mobilize secretions, alter the VQ, and let's see if there's another one. Improve or prevent atelectasis. Of course, that's the same thing as IS, right? We want to improve or treat atelectasis. So positive pressure breathing can do all the things that incentive spirometry can do, right? The negative pressure or natural. PPB does the exact same thing that IS can do, but a little bit more, right? It can do all the same things IS can do, but it can also give medicine, right? It can also alter the VQ ratio, right? Improve the IE ratio, right? That's inspiratory time to expiratory time, right? If I'm pushing slow, deep, positive pressure, I'm gonna make the I time longer, right? So those things are the secondary things that IPPV can do. It can also decrease the CO2. That makes sense because we ventilate, we blow off what? CO2. So if I'm pushing more volume in you, then I'm decreasing your CO2. Because the more volume I put in, the more volume is going to come out, right? If I'm pushing volume into your lungs, it don't just disappear, it comes back out. You're temporarily decreasing the CO2. Decreasing, because you make it, if it's already normal from normal breathing, if I start forcing air into your lungs, you're going to start blowing off more CO2 because it's more volume. If you had 300 of volume in your lungs, in and out, and I start giving you hyperinflation, now you're blowing out 500 because I'm blowing your lungs up and letting that air out, then you're blowing off more CO2, okay? The faster you breathe or the deeper you breathe is going to drop the CO2. the slower you breathe going to increase the CO2, right? Because you exhale CO2. So the faster you exhale, or the more you exhale, you drop the CO2. The slower you exhale, or the less that you exhale, you increase the CO2. Because that's what's coming out. It's either coming out or it ain't, all right? All right. This is a picture of some of the contraindications. We have some contraindications of Ippb. Now, this is the reasons why you would not do positive pressure breathing. Just like IS, we have some contraindications of IS and some hazards to watch out for. Mostly the contraindications was because they just can't do it right? The patient's unable to do it, they cannot cooperate, or it hurts too much to take a deep breath. So you wouldn't do it. But positive pressure has its own set of contraindications because now we are forcing air into the lungs. Well, the absolute contraindication, make sure you highlight this, the absolute contraindication is an untreated closed pneumothorax. That is definitely going to be one of your test questions, oral questions, board exam questions. Absolute contraindication of positive pressure breathing is an untreated closed pneumothorax. That's also known as a tension pneumothorax, a tension pneumothorax. And what happens is, notice this lung over here. This is the lung, right? This is the patient's right lung, okay? This is his right, not yours. This is his right lung, right? But what happened was it used to look like the left, but it popped open, right? You kept forcing all of that positive pressure in there and you popped the lung. So now the air comes out of the lung and hits the thoracic cavity. So when it's hitting that thoracic cavity, it can't go out your skin. It's going to turn around and come back pushing against the lung. And that's how you have collapsed lung. That's a tension pneumo. That means you have a pneumothorax, but it can't get out. The air cannot escape. So his right lung is just getting bigger and bigger, and his chest is just getting bigger and bigger and bigger. His lung is getting smaller, but his chest is getting bigger and bigger because that air is trying to get out, right? But it has no way to go. It has no way to get out. So it's trapped. It's a tension pneumothorax, and that causes the lung to collapse. And if you don't treat it, it starts to push the heart, deviate, right? See, it says trachea deviated. See, your trachea should be straight up and down, right? Look at my marker. My trachea should be straight up and down, but because I have the tension pneumothorax, which air started pouring out and started hitting my rib cage and start pushing back against my lungs, and now I have collapsed that lung, but the air is still doing it. So it's pushing, pushing, pushing. And now my trachea is deviated to the left, right? It's pushing my heart and it's starting to partially collapse my left lung because that air has to get out. And how we treat that, it would be a chest tube. We would stick a tube right here. If I look at my marker, we would stick a tube right here, straight through here, boom. And all that air would just, you can hear it just hiss out. You'll hear it come out. And when that happens, this lung will pop, 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 pop right back open. Okay? All this deviation would then go right back to where it's supposed to be once we get rid of that air, all this air. Because this is not lung. This is just open thoracic cavity. This is the lung here. It has popped, pushed air out against the parietal pleura, and now it's pushing back because it has nowhere to go. It can't come out your skin, so it has to go back toward the lung. When it does that, it collapses the lung and pushes everything to the opposite direction. So if I know that, would I give somebody positive pressure? No, but I'm going to force more air in there. I'm going to make it worse. So if you know they have an untreated closed pneumothorax, that's an absolute contraindication. You will not do positive pressure. Uh-huh. Huh? In the lung, actually, the actual lung, yes. Because right here, this is air right here. All this air right here is pushing against your lung. So it's just trapped air inside your thoracic cavity. So I will go in between your ribs right here and stick a tube. And as soon as I stick that tube in there, all that air is going to run out the tube into the chest tube container. Okay? All that air that's trapped right here is going, once I stick a tube right here, boom, All that air is going to run out. Probably air, blood, fluid, all that stuff is going to run straight out. And then the lung, see this lung right here, is able to pop back open. Okay? Because the air is coming out. It's coming out of you. You giving air, and it's coming straight out of the lung. It's coming out the hole, right? And so, but it's going into the cavity and has nowhere to go, right? It can't come out your arm or come out right here. It's trapped in here. So, but as you keep on breathing, you keep on pushing more air in here. So then you start to force the lung to close, okay? You start to collapse it because air has to go somewhere. It can't go out your rib cage. It has to go back towards your heart, okay? And so what happens is this collapses. So then I would take a chest tube, emergency chest tube, and stick you in between the intercostal space. Stick the tube right into that space there, and all that air will, you'll hear it do that, and it will come out, and then this lung can then go back toward the wall, right, like it's supposed to, okay? All right, so the absolute contraindication is a closed pneumothorax, an untreated closed pneumothorax, also known as a tension pneumo. This is a picture of a tension pneumothorax X-ray. Notice how the heart is deviated over to the side. Look at the chest. It's bowled out on this side because, and look how black this is. We always said that air is black. It's supposed to be black. But I should still see some ribs right here. See how I can still see the rib markings? But on this side, it's super black. That's a pneumothorax. It's so much air in there now, I can't even see the ribs. So that air is pushing against the wall right here, but it has nowhere to go. So it has to come back toward the lung. And it has collapsed the lung so small, you barely can see it. And it's deviating. Look at this. Trachea should be straight up and down, but it's slightly deviated this way. Okay? So that's an X-ray of a tension pneumothorax. And if the radiologist sees that, that's an emergency chest tube. You bought yourself an emergency chest tube immediately. Because you can't breathe. You inhale, but you can't exhale. Inhale, but you can't exhale. That's terrible. You just get bigger and bigger and bigger, eventually to, you cause some damage, some real damage, okay? All right, secondary contraindications, because the number one contraindication is a untreated closed pneumothorax, right? Or a tension pneumo. That's the number one contraindication of positive pressure breathing. The secondary contraindications, now we have some secondary. Endocranial pressure is greater than 15 millimeters of mercury. ICP is intracranial pressure. Okay, that's the pressure on the brain. Some patients come in an emergency trauma situation, and they have bleeding in the brain. And to know if you have too much pressure on the brain, you collapse that brain, you want to die. Okay, we cannot let the brain be smushed or collapsed. So we have they drill a hole in your head and put a bolt in your head, and it's connected to a monitor. And it will tell the person or the practitioner what the pressure is inside of the intracranial space, inside your cranium, inside your head, right? If you have patients who have those, you still have to do the lungs, right? But you have to, look at if the intracranial pressure is reading greater than 15, you don't do positive pressure. Because if I introduce positive pressure into the body, that pressure will affect the pressure that's in the head, okay? It's going to affect the pressure in the head, and that's to cause more further brain damage, right? You can fix the lungs all you want, but if the brain is gone, patient is gone, okay? So intracranial pressure is greater than 15 millimeters of mercury, not centimeters of water, but millimeters of mercury. Oh, all right. If they're hemodynamically unstable, so if their blood pressure is really low or blood pressure is really high, you got to watch it. If their hemodynamics are off, don't do it, okay? Because we said, if we put positive pressure in the lungs, we're going to decrease venous return. Remember we said that? An increase in pressure will decrease venous return. So if the superior vena cava and inferior vena cava have less blood getting to the heart, then that's less blood that's going to leave the heart, right? And the blood pressure is based on how much blood and pressure is coming from the left side of the heart, right? So the vena cava and the veins are on the right side of the heart. So if I decrease the venous return, then I'm going to decrease the cardiac output. If I have a decreased cardiac output, I have a low blood pressure. That's hemodynamics, okay? Blood pressure, pulmonary capillary wedge pressure, central venous pressures, pulmonary artery pressure. All of those pressures are hemodynamics, which you will learn in 240, okay? That's hemodynamics, that's straight up ICU, okay? Only people who are strong in hemodynamics will be in ICU. Everybody else who barely made it through will be given breathing treatments. The manager will not put you in ICU if you don't have it, okay? Because they are extremely critical. Anybody who's hooked up to hemodynamic monitoring is critical. And you have to be able to say, okay, I need to do this to help them ventilate, but hey, I don't want to cause this to happen because I'm trying to ventilate, right? You have to be able to look and know your patient and how severe their illness is, okay? So the secondary contraindications, intracranial pressures greater than 15. The patient is hemodynamically unstable. If he's had recent facial or oral or skull surgery, tracheal esophageal fistula, that's a hole between the trachea and the esophagus. Remember, we said that the esophagus and the trachea are right beside each other. The trachea is anterior to the esophagus. That means it's in front of, all right? But sometimes there's a hole in the trachea that goes into the esophagus. That's called a fistula, all right? And wherever it is, you name it. So it's a tracheal esophageal fistula. That's a hole in the trachea that leads into the esophagus. So if I'm forcing air into the body, that air is going to go through that hole and go into the what? And which leads to the what? The esophagus does not lead to the lungs. Stomach. So now I'm trying to hyperinflate the patient, right? I think I'm doing good. I ain't doing nothing but making his stomach bigger, okay? So you have to be careful. Plus, you make that hole even bigger. So when you do stop, he can't breathe because every time he takes a breath in, it goes through the hole into the stomach and it's not getting to the lungs, which causes all kind of problems, right? Deoxygenation, hypoxia, all of that happens. So you have to be very careful. Active hemoptysis. What is hemoptysis? We said frank hemoptysis is what? Blood in the hemoptysis, active hemoptysis. Coughing up blood. Hemoptysis is when they're coughing up blood. Frank hemoptysis means really bright red blood, right? So if somebody's actively coughing up blood, you don't want to give them Ippb. Active TB, what's TB? Tuberculosis. If they got tuberculosis, I don't want them exhaling all that tuberculosis into the air. If I force air into his lungs, he's going to exhale what I forced, right? And tuberculosis is an airborne disease. It's not droplet, it's airborne. All he got to do is breathe around you and you got it. The particles are small enough to be aerosolized, right? When you sneeze, those are not really aerosolized. Those are just droplets that you forced into the air. But they end up dropping, like maybe 3 feet away from the patient, they'll drop and hit the surface. So somebody who's sneezing up disease, they will be in droplet precaution. So they tell you don't be between 5 feet of that patient, right? Be careful, or make sure you have gown and gloves and all of that, mask if you want to be within 5 feet of the patient, right? Contact isolation is if you want to be touching anything that the patient touched. You got to have gloves, gown, and all of that. Airborne isolation is when it's airborne. As soon as you walk into the room, if you don't have an N95 fitted mask on, you are going to catch it. Okay? All right. And blebs or bullae. Blebs or bullae. Blebs or bullae are like your lungs blowing a bubble. You ever chew some gum and blew a bubble? You know how you blow little bubbles and pop them back in your mouth? Imagine if your lungs blew bubbles. Those are called blebs, and they are painful. Anybody had a boil on your leg or boil on your body, and when it starts coming to a head, it's really, really sore? It gets hot and the skin gets real thin because it's getting ready to break through the surface. right? You might be too young to have boils, I guess, but a boil, you can get up like an ingrown hair or whatever, it turns into a boil, right? And it's a bump, and it starts to get shiny because it's spreading the skin real thin. It hurts real bad, and eventually the pop and pus comes out of it, right? Well, the lungs can also have a bleb, and so that's like the lungs blowing a bubble, but the lung, the visceral pleura gets real skinny, and if it pops, that's a pneumothorax, right? It can either be just a bubble that didn't pop, or if a bubble that pops becomes a pneumothorax. But that pain, right? When that visceral pleura, remember that's the lining of the actual lung is the visceral pleura. And the lining that's on the ribs or the bones is the parietal pleura. And in between is the the pleural space. Well, if that bullae, right, or that lung starts to blow that bullae, right, that skin or that visceral pleura of the lungs becomes so sensitive and so painful before it pops, right? It's just like a sore boil, okay? I'm going to show you some pictures of these as well. Now, this is the ICP boat here. This is a typical ICU individual patient that you may have, especially if you are in trauma. You are in charge of this ventilator. This right here, this is his ventilator, right? Going to his machine. You in charge of that. You are in charge of his breathing. You are in charge of his ABG. You are in charge of his ventilator, the settings, the troubleshooting, all of that. That's respiratory. Look at this over here. These are all his pumps, all the medicines that he's on. You got to know what these medicines do. When you get to that point, you're going to have to know what dopamine does. You're going to have to know what Levophed does. Remember we said that's liquid adrenaline or epinephrine, also known as Levophed, right? You got to know what fentanyl is. You got to know what Versed is. You got to know what Dilaudid is and what it's doing to your patient as it pertains to his breathing, right? But to show you that, I just say that to show you he has a boat in his head. See that boat, right? He has had a car injury. Looks like he has a tourniquet on, like you girls be wearing them waist trainers. Well, this is a real waist trainer for you. This is keeping his insides together. If I was to let this go, all his insides will just fall apart. He is that injured. Ribs tore up, broken up. His pelvis is probably shattered. All those things from a bad car wreck, okay? Look at all the scars and bruises on his hands and stuff. There's a little minor stuff. Look at all that. He might look like he might have had a motorcycle crash because he got all these abrasions on him, right? Well, he's knocked out. He's completely comatose on the ventilator, and he has a boat in his head. This is the boat closer. Another patient's boat that's closer. This measures the pressure inside the brain. Now look at this diagram. See how far down in the brain it drills? The neurologist, the neurologist, doctor, surgeon, right? The brain surgeon will come in and drill into your head and lock it in place, wrap it up with this bandage type stuff here that's really sterile. And this right here will measure the pressure. This is connected to a monitor, which will tell me my intracranial pressure, whether it's 5, 10, 15, 20, whatever it is. And so if you come into this guy's room and you know he needs hyperinflation because he got to be breathing too, if them lungs ain't working right, ain't nothing else working right, right? But if his ICPs are greater than 15, you cannot do positive pressure on him. He's already getting positive pressure because he's on a what? Ventilator, right? So because he's on a ventilator, he's already getting positive pressure. You don't want to add to that by doing positive pressure ventilation, right? Or Ippb. So we will monitor his endocranial pressures with this boat, right? And that lets us know whether we need to do PPB or not. Okay, so that's the intracranial boat. All right, the next thing, tracheal esophageal fistula. The fistula, that's a hole in between the trachea and the esophagus. Notice, somebody tell me what these are right here to know where I am. This is a bronchoscopy. How do I know? Well, one of them might be, but these are the tracheal rings, right? Remember the trachea has those rings, C-shaped rings going all the way down anterior, right? So if I'm looking like this and the rings are on top, then that means this is the patient laying on his back and I'm looking down his trachea because the rings are around the front. Notice they're not at the back. The tracheal rings are across the anterior surface of the trachea, correct? And we said that the esophagus is posterior to the trachea, right? That means it's behind it. So the hole is right here. So what's behind this hole? What's behind this? The esophagus. Because the esophagus will lay right behind the trachea. It's posterior to the trachea. So that's another thing. You got to know your directional terms, right? Because when you do a bronchoscopy and they get in with the camera, you'll get lost. You have no idea where you are. They all look the same. But knowing those rings are on the front of the tracheobronchial tree, then you know left is left and right is right. Now, if these rings were down here, then that means I'm backwards with my camera. And right will be left and left will be right when I'm going through with the bronchoscopy, okay? So just knowing that you know that the tracheal rings are in the front of the trachea, right? So if they're in the front of the trachea, that means I'm looking, as the patient is laying on his back, I'm looking down his trachea, right across here. Look at me. Tracheal rings across the front, right? So I'm looking with the scope in this picture because the tracheal rings are on the top. And I know that the esophagus is behind or posterior to the trachea. And so if I see a hole right here, I'm going to call this a tracheal esophageal fistula. So as I'm pushing air into your body, into his lungs, some of that air is going through here, okay? Some of that air may very well go through here, okay? And that will go into his esophagus. And then you may get some vomit back at you if you're not careful. And also, what if he vomits through here? That means the vomit is going to go where? If he vomits some up through here, it's going to go where? No. Look right here. If he vomits and some of it comes up through this fistula, then it's probably going to go into his what does the trachea lead to? The lungs. Stomach. No, not the trachea leads to the lungs, right? So if it comes up from the stomach into this little, through this little hole here, because the esophagus is behind the trachea. This is the trachea. The esophagus is back here. You can't see it, but it's posterior to the trachea. So this hole will lead down into the esophagus. So if he throws up or vomits, some of the vomit will come through this hole and go into his trachea down into his lungs. That is called aspiration pneumonia. That's extremely critical. If somebody throws up and gets down in their lungs, that's hydrochloric acid and food contents in the lungs. That's nasty. That's infection immediately. It's called aspiration pneumonia. You can kill your patient like that, okay? You got to know what you're doing. These are those bubbles I was telling you about, blebs or bullae, like blowing a bubble on the lung. This is showing you a normal lung here. This is the lung that have a little patch of blebs or bullae. See the little bubble? They look like little bubbles, right? The visceral pleura is blowing little bubbles, right? Look down here. This is an actual picture of a bubble on a lung. That looks painful. See how thin the skin is right there? See that? How thin that visceral pleura is, right? Super thin. These down here are showing them how they're trying to correct it with surgery. That's a laparoscopic tool he's using to do surgery, right? Surgically remove them and close it up. But if this pops, then you have a pneumothorax, right? So look right here. You got the bubbles on the lungs, right? If you keep on pushing positive air in there, they're going to keep getting thinner and thinner and thinner, just like you blow a piece of bubble gum and you keep blowing, what happens to the bubble? So if you had a bubble gum in your mouth and you blew a bubble and you just kept blowing into it, what happens to the bubble? It pops. It busts, right? So once it busts, then air starts coming out of that lung. And notice, it's showing you how the lung collapsed because now you're supposed to have just a little bit of pleural space. Look at this space right here. Between the parietal and the visceral pleura is the pleural space. That's normal. But once air gets in that pleural space because this bulla has busted, right? And air is now rushing against the thoracic wall, has nowhere to go, so it starts coming back toward the lung. So now you see this lung has collapsed. Okay, that causes an untreated closed pneumothorax, right? So bullae or blebs are very, very painful and they're dangerous if you're pushing air in there. Okay, you got to get it surgically removed or let it dissipate on its own before you can add positive pressure. Okay, now getting into some real, say you have this situation and you got somebody who needs to be ventilated though, but he has a lot of blebs and bulli on his right lung. Well, we can do what's called independent ventilation, right? And I can ventilate one lung instead of both lungs on the ventilator. I can ventilate only one lung if I need to help move that CO2 and get that oxygen in the body while I fix on that other lung. So it gets real deep and real interesting and fun of what you can learn as a respiratory therapist and what you'll be involved in. And I remember when I was in trauma, somebody had got shot in the chest, they cracked the chest when they drilled, opened up the sternum, pulled the lungs out of the cavity, and I was holding the lungs in my hand while I'm ventilating them while they're looking for bullet fragments, right? Hold the lungs in my hand, just be real still, the lungs is opening and ventilating, opening and closing while they're digging through the cavity, trying to find bullet fragments, because those bullet fragments got to come out, huh? Yeah, I was still connected to his trachea, I was just holding it, right outside of his chest. If you're the therapist, yeah. If you're in the middle of a heat of trauma like that, yeah. Because you'll be at the head of the bed. When the trauma come in, you at the head of the bed. I was holding it just like that while they were looking for bullet fragments. They found the little fragments and they placed the lungs back into the cavity and wired them back shut. Okay? That's a very, very rare occasion, but it does happen if you work in trauma. Okay? Therapist is more than breathing treatments. All right, and so if you don't have it, or you know what I'm saying, they don't seem to want to do stuff like that, they'll never put you in trauma. Complications, of course. If I'm giving positive pressure, you want to have some complications. You want to have barotrauma, which is stretching the lungs, even causing those blebs or bulli. And if you keep on blowing, you want to pop, and that becomes a pneumothorax. Nosocomial infections. That's hospital-acquired infections. When you're using this machine on one patient and you're using that same machine on another patient, even if you change the mouthpiece and the filter, you still have a chance for nosocomial infection. Hypocarbia. What does hypocarbia mean? Low what? Hypocarbia. What is carbia? Told you carbia and capnia, all the same thing. What is? Carbia. What is carbia? CO2. CO2 is ventilation. It is an acid. It is respiratory. It is carbia. It is capnia, right? All of that is CO2. So hypocarbia means a low CO2 level. Because I'm giving positive pressure. I'm pushing volume into your lungs. So I have to be careful. If I put too much, I may make you blow off too much CO2. So that's a complication or a hazard I have to watch out for. Okay, not to put too much, because I don't want to tear the lung. I don't want to give you an infection. I don't want to overdo it and blow off too much CO2, right? I don't want to hyperoxygenate you either, because the more volume you take in, the more oxygen you're taking in. So it's possible to be hyperoxia, okay? So if I'm a COPD patient, I have to be careful on what I'm using my gas flow, right? If I'm using a machine that's a positive pressure machine and I'm using it connected to oxygen, I gotta be careful because I'm pumping all this extra oxygen into my COPD patient, right? So I have to be careful with that, because you know what happens if you give too much oxygen to your COPD patient. Right, so hyperoxia is a problem. Tachypnea, what's tachypnea mean? Fast what?
Breathing.
Thank you. Fast breathing. You don't want to do it too fast. You're giving him the pressure. He's sucking it. Hold on, give him a break, because he's breathing too fast. Because he's going to breathe too fast, it's going to lead to him breathing out too much CO2, which is going to lead to hypocarbia. Also, tingling, hyperinflation or hyperventilation can lead to tingling in the fingers, feeling dizzy, like you're about to pass out, right? Because those who panic, you see somebody who panic and they just doing that like that, they end up passing out because they blew out too much CO2. Okay, they became hypocarbic and they fell out. So a lot of times you used to see people will put a paper bag over their face and to keep them from passing out, because what it does is it catches that CO2 and gives it back to them so they don't blow too much off, right? That's why we use the paper bag over somebody's face, not because they're ugly, but because we don't want them to have blow out too much CO2. Gastric distension, again, what if he's swallowing it and every time you give him that breath, he's swallowing instead of taking it into his lungs? It's going to go into his stomach, and his stomach going to get bigger and bigger and bigger, and eventually you're going to have vomit all over you. So, don't wear your brand new Air Force Ones to work. Don't wear your brand new Air Maxes. Oh, she cute. Look at her. She got on her new little scrub, new little job, and she got the little scrub colored for the hospital, right? And now, not only did she got that color, she went and got her some new shoes that match her little scrubs and everything like that. And day one, she got in there doing that, and somebody threw up all over her new shoes, all down in your socks, right? You can't go home. Oh, they do. They do. I have seen people do hair in the department, have curling irons and everything. Women, older women, they do that. They get to the department early, especially they day shift. All they want to do is breathing treatments anyway. They day shift, they get their little assignment, they eat their breakfast together. If they need to curl up a couple of curls, they'll curl it up a couple of curls and then go out there and do their job. It happens. And I don't knock them. I mean, you doing this right here so you can work smart and not hard, right? You in the department chilling, making good money, not working like a factory and it's 10 degrees outside or it's 200 degrees outside. You working laid back because you worked hard for it. The hard work is doing right now. When you get to the hospital, it should be second nature. You make decisions, you do it, and you go chill out for 2 hours. Go around, do some more work, sit out for 2 hours. Do your next round, sit down for 2 hours. It's easy work, right? Treatments is the hard work because you're running around all over the place. The ICU, you don't do that much. You just monitor, make changes, intervene if there's a life-threatening emergency, but they ain't gonna put just anybody in the unit, okay? And they're gonna find that out when they do your clinicals. While you in clinicals and they see, oh, if you do get a job, you'll never be in my ICU, right? Or when you get a job, when you graduate, come see me ASAP. I got a job for you. All that depends on how you are in your clinicals. Are you on time? Are you willing to learn? And are you, knowledgeable of what you're doing and you taking it serious? That's an interview every day. All day is an all-day interview for 10 weeks, right? For each one. And when you graduate, you have them say, hey, as soon as you graduate, come see me. I got you. Or when you graduate, don't look this way. Okay? And they can blackball you too, especially if you got a bad attitude. You don't want to come and it's always the hospital's fault. Y'all always doing this, or that's all y'all think of, and it's y'all fault. Everybody's fault but yours, right? You will get blackballed quick in West Memphis, Mississippi, and Tennessee. You can hang it up. You might as well go move somewhere else and become a respiratory therapist, okay? Your attitude speaks volumes. All right, impedance of venous return. That's what we just said. When you put positive pressure inside the thoracic cavity by pushing positive pressure in the lungs, you will impede the venous return. So the blood that was coming back to the heart is now slacked down. It's like stepping your foot on somebody's heart. If my foot is on the heart, then the blood can't get to it. And the blood can't get to it, then you can't get blood out, right? Air trapping. Air trapping is always a hazard of Ippb, because what if you give the next breath before he get the last breath out, right? So a COPD, if you're doing one for a COPD, and then you don't give him time to exhale, and you force another breath in there, then the air that never came out is now trapped, right? And that hurts, like having gas. You ever had gas and you belch and say, ooh, that feels better, right? That's trapped gas. You can do that mechanically if you're not careful. Increase ICP, we already know that, right? You want to increase their intracranial pressures when you add positive pressure to the body. See all these complications when you go unnatural, right? Positive pressure is not the natural way to inflate. Negative is natural. Remember, negative, natural, negative, natural. Negative is when you're using your incentive spirometer and you're sucking in, causing it to be more negative, right? That's the natural way you're supposed to do it. But when we start having to force air into the lungs, we start coming across all these complications because it's not natural. All right. Hazards continue. O2 induced hypoventilation. You already know that. You add too much oxygen to a patient. If he has COPD, he may become hyperventilating, right? Too much oxygen because you knocked out his hypoxic drive, right? And that really depends on whether you're using air as your power for your machine or you're using the oxygen wall for your power. Some of them are hooked for oxygen. That way you can give them oxygen while you're doing the treatment. But some of them can be used on just air, right? So then you're making sure you're not giving any extra FiO2 to a patient, right? But most of them are oxygen, so you have to be careful, okay? Have to be careful. You cannot put an Ippb on somebody or a positive pressure breathing hyperinflation and just leave and say, I'll be back in 10 minutes. You have to stay with them when you do this, okay? You have to stay so you can monitor, monitor, monitor. If I have decreased venous return, then I'm going to have a decreased cardiac output. That's just common sense. Here's the heart, right? Here's the heart. This is the right side, the venous side, right? The pulmonary side. If the blood is no longer coming to this side, then that means I'm going to have a low amount coming from the left side, right? It's as simple as that. Think about your money. You got bills, right? Well, you got money coming in and you got money going out, right? But if something happens and your money gets cut from coming in, that means you got less money, what? Going out. Same thing with your heart. If you have less blood coming back or returning to the heart from the body, then you're going to have less blood that gets to make it back to the body. Because it got to go through the heart to come through, right? It comes through the heart, to the lungs, to the heart, body. To the heart, to the lungs, to the heart, body. Well, if you don't have it coming to the heart, then you're going to have less blood going into the lungs, less blood coming back to the left side of the heart, and less blood going to the body. And the blood that goes to the body is called cardiac output, C.O, right? Which is 5 liters per minute, because that's the VQ mismatch, right? VQ is ventilation to perfusion. You should have 4 liters of alveolar minute ventilation to 5 liters of cardiac output, 4 to 5, that's normal. Well, if you have this positive pressure in your lungs, now you have less blood flow because positive pressure will impede the venous return, especially if you have the inspiratory time for a long time or you have too much pressure, okay? See what's next before we take a break. May cause or worsen hemoptysis, right? If they got hemoptysis, you shouldn't be doing anyway, but it could cause hemoptysis. You're putting all that positive pressure and they have some little blood vessels in their throat or trachea that are kind of already thin and about to burst, and you stretching all of that, you may tear a blood vessel and make them cough up fresh red blood. Or that fistula. You got that tracheal esophageal fistula in there. Or one of the blebs have busted. And now you're coughing up that blood that came from that bleb that just busted. Okay, so you have to be careful. Hyperventilation. We already said blowing off too much CO2 is hyperventilation. So hyperventilation causes hypocarbia. Hyperventilation causes hypocapnia, right? Because capnia is CO2. And if I'm hyperventilating, I'm blowing off too much CO2. So hyperventilation will cause a hypocarbia. Now, hyperventilation itself. Let's look at some of the things about hyperventilation itself, and then we're going to take a break. Hyperventilation itself can cause dizziness, loss of consciousness, right? Pass out because they're blowing off too much. If somebody's panicking, blowing off too much CO2, they can pass out. Tetany, right? Tetany is when your body locks up and all your muscles tense at the same time. That's tetany. Paresthesia, when your fingers and stuff are tingling. Your hand, you lose the feeling in your hands and feet. That's paresthesia. And paresthesia, they talk about paresthesia a little bit more. That's decreased cerebral vascular CO2 during hyperventilation, causes vasoconstriction and decreased cerebral blood flow. Okay, that makes you feel lightheaded, tingling in your fingers, tingling in your hands and your feet, stuff like that. Because when that cerebrovascular CO2 is low, that causes that causes vasoconstriction of the blood flow in your brain. Okay, that's why CO2 is important. Yes, it's a waste product, but it's still important. You got too little of it, and you're gonna die. Too much of it, you can die. Okay. All right, let's take a 10-minute break. It is 2:55. Come back at 3:05. 3:05, we're going to get into the physiological effects of IPPB, the physiologic effects of positive pressure breathing. All right. We'll stop the recording while we take this break. Come back and finish up for today. All right, guys. So physiological effects of IPPB, just like in a nutshell, IPPB or positive pressure breathing can cause increased intrapulmonary pressure, right? Decreased venous return or worsened by the inspiratory time. So I'm already impeding the venous return, but if I have the I time set to a long time, then I'm impeding that much longer, right? The longer you have the I time, the longer you have that positive pressure being applied. And this may cause a decreased cardiac output and also mechanical bronchodilation. We just learned that there are some medicines we can use that give us bronchodilation, right, by pharmacological agents. Well, we can also mechanically bronchodilate you by forcing air into the bronchioles, right? And that will open up the bronchioles as well. All right. Also, alter IE ratio, alter the VQ ratio, mobilize secretions. Generally can increase the PaO2 and decrease the CO2. That's for a moment, right? Because as we're pushing that volume in, you're going to decrease the CO2 because you're blowing off more. And the more air that you take in, the more oxygen you take in as well, okay? Decrease the work of breathing. If somebody's short of breath, positive pressure will decrease that work of breathing because we're forcing air in, okay? Now, the setup. Whenever you have your positive pressure, you want to make sure you don't have leaks because the whole key to this is forcing pressure into the patient's lungs, right? That's the whole goal, is to force pressure or volume into your patient's lung. And if I have a hole or a leak in my system, then that pressure escapes, right? If I'm not holding my mouth correctly, it can escape out the sides of my mouth. Or if I don't have all my parts connected tightly, pressure or air can be escaping from there in a leak. Make sure you have to instruct your patient properly, right? Let them know that you can really get a rush of air, so relax. It's normal, it's okay. Know that it is a passive treatment, right? Incentive Spirometry is active. You have to suck in the air, right? You have to breathe in slow, deep with an inspiratory hold, and then exhalation is passive. But the treatment itself is active. The patient has to do something. Well, on the IPPB or the positive pressure breathing, it's pretty much a passive treatment. All they have to do is kiss on it, and it will give them or trigger a breath. That breath will continue to blow in until the pressure is reached, and it will stop or cycle. So again, slow, deep with an inspiratory hold, maintain a good seal, explain the nature and expected results. Mr. Johnson, you're going to get a nice rush of air, but that's what we want. We want to inflate. We're trying to hyperinflate your lungs, make your lungs blow up a little bit for us so that we can get more volume, more oxygen, more ventilation, right? And help you treat atelectasis. All right, so again, coaching the patient is very important. Keep them calm, reassure that they are relaxed, right? Because I'm telling you, this is the first time, sometimes it's the first time a patient has been introduced to positive pressure, right? If somebody was to put a straw in your mouth and blow on the end, that you're going to be ready for that, right? You're not just ready for that naturally, okay? So keep them calm. Verbally instruct them in the timing, right, of inspiration and expiration, because you're going to start learning about trigger and cycle, right? When I trigger a breath, and it cycles, right? Trigger means to start inspiration, and cycle means to end inspiration. Total relaxed exhalation, just relax. Blow in and just relax. It's gonna come out on its own. So you also have to monitor. Now, what am I looking for while I'm monitoring the patient? Well, I want to make sure they're not falling out on me, right? I want to make sure that their breath sound, are they improving with this positive pressure breathing, right? Or with regular incentive spirometry, right? We want to open them up. The whole goal is to treat or prevent atelectasis. So when I listen to them, I should hear nice, normal vesicular breath sounds, right? Vesicular breath sounds means normal. Vesicular means normal. You will see that word, and I'm sure he said it during that breath sounds laboratory that you did. Tidal volume. Remember we said 3 times, well, we want the 3 times their predicted tidal volume. We want to get the 3 times their predicted tidal volume. So you want to monitor their tidal volume, right? And make sure it's 3 times predicted. So that's what we want. Because if we're just doing regular tidal volume, then that's not therapeutic. We're trying to hyperinflate. So if I'm monitoring their tidal volume, it should be 3 times that, and that lets me know I'm doing what I'm supposed to do, okay? Respiratory rate, so they don't do it too fast, right? Pulse, what if his pulse increases by 20? I stop the treatment, right? In any form of respiratory therapy, if your patient's heart rate increases over 20 times, you started at 80, you get into your treatment, now he's 102, then you need to stop, okay? Anytime they increase by 20, you need to stop the therapy. So you're monitoring their pulse, right? Verbal response, if they tell me I can't do this, this is too much, this hurts, or whatever, I'm feeling lightheaded. Those are all verbal responses. You need to monitor that. Add subjective responses. Are you feeling all right? You know, something he can answer you right back. Are you feeling okay? Are you dizzy? Do you feel tingling in your fingers? Is this hurting, right? Ask those kind of questions because you're monitoring your patient because he's going through a nice therapy here. And it's very important that you do it right and you monitor, because if you do it right and you get to the point you don't even monitor your patient, you don't know if you're helping or hurting, okay? This is a picture of the metaneb I talked about, which gets 3 breaths in one. It has, this one right here is high frequency, right? High frequency oscillation. So it does this. So it's blowing puffs of positive pressure in the lungs, right? Intermittently, quickly, or I can do it slowly. With this part here, I can do with this one, I can with this one, right? I can control that. I can turn this on just nebulizer, right? Where nothing happened. He's just simply getting his nebulized treatment, right? Or I can turn it down to this one, which is positive expiratory pressure, and it's hyperinflating, right? And so he'll put the mouthpiece in, and he'll blow against that force. It'll be blowing into him, and he exhales against it, and it pops those lungs open. And how much pressure we're generating is labeled right here, right? This is what we're looking for. How much is it generating when he is pushing the lungs or he's exhaling against that pressure? We can control the flow with this one, okay? So that's hyperinflation, CPT, right? And medicine, all in one. That's why we say the metaneb is a great device invented by Hill-Rom that knocks out 3 birds with 1 stone. Because you have several orders on a patient. The doctor may say, I want CPT, I want hyperinflation, and he can also give him breathing treatments. Well, if you do one thing at a time, you'll be in there all day. You're going to do your CPT, then you do your hyperinflation, and then you open up your medicine and do your medicine. Or you can do all 3 with this one machine at the same time. So that's 10 minutes tops, you're out the room. Yes, the CPT, hyperinflation, and deliver medicine all at the same time. All right, so that is the end of the hyperinflation and your either in a negative form or positive, okay? Negative or positive. Tomorrow we will get into more about the trigger and cycle to make sure you understand that and start getting into our obstructive and obstructive diseases, okay? This unit is hyperinflation. It's also obstructive versus restrictive diseases. So it's heavy, okay? It's heavy. So we just went through all of the hyperinflation part of it. But I will touch on tomorrow trigger and flow cycle, trigger and cycle, and some of the ventilator mode, basic modes that you see: assist, assist control, and control. Right? Those are three modes that are used in hyperinflation at times. Okay, depending on what machine you're using. So we will go over that tomorrow and break on into our obstructive diseases. Okay. Your homework has been put in the module already. I put it in there earlier today. It's mostly a blast from the past, but it's RT210J number 1. That is due by midnight tonight. Okay, that is your homework for attendance and will be graded. Make sure you turn it in. Okay, for those who are here, if you need to go back, watch the recording again. Make sure you read the pages, the chapters that you're supposed to read for this section. Again, the bird and the Bennett PR2, we don't use them anymore. So when you start reading about those, you can kind of skip that part because we're not going to test you on those two machines. They were prehistoric machines or ventilators that were used for IPPB, but we just stopped using those or stopped testing on those. So we're cutting that out of our unit. Okay, so when you start reading about that, you can just skip that part. You won't have any questions on those two machines because you used to talk about the position of the piston on this, what it's made of. We don't do all of that anymore. Okay, but we will talk about trigger and cycle on tomorrow. Okay, and we will get into obstructive diseases. Right. The lab is in the syllabus. The lab day is in your syllabus, and be prepared on that day. Don't forget, we have a couple of makeup days that are in the syllabus for makeup days. Okay, if you have something that you don't need, that you need to make up, it's your responsibility to come to us and let us know, hey, I need to do this one and this one, or that one and that one, right? I don't have a list of everybody who's done what. I don't keep up with that. It's your responsibility. Okay, you tell me that you need to make up this or that, and we'll set up a makeup day for you. Okay, now I think we have 2 major makeup lab days, which are after the final, because the final, unfortunately, is going to put some people out of the running to go to 220. Right, they're not going to make it. So once that final hits, then we can consider, it's a little bit better because people that need to make up labs no need to make up a lab if you're not going to pass. All right. So that's why 2 of the lab days, complete days, were put after the final. Okay. So we only have 10 students, and everybody's not going to pass. So we should be able to get everybody knocked out. Okay. If you need anything special, you need to email me because I will be over on some Fridays to help another student. If you need to try to come up here early on a Friday or something to knock out a lab. Okay. Again, homework is already in your module. That's yours to keep. Whenever you do come, you can get an Incentive Spirometry if you come up here to the campus, or when you come for lab, you can take one home with you. And I will see you guys tomorrow.